Our next speaker is Dr. Gerald Raymond. He's an expert in the treatment and management of ALD. He's now at the University of Minnesota, having moved there a year or two ago? 2 years ago. He's in the Department of Neurology and had spent prior to that a long time at the Kennedy Krieger Institute here in Baltimore. He works with the Inherited Metabolic Storage Disease and Bone Marrow Transplant Centers at the University of Minnesota and is involved in the Center for Organ Drug Research and the Center for Magnetic Resonance Research. He got his bachelor's degree at Fairfield and then went to UConn for his medical degree and did a residency at Peds in Johns Hopkins, so he came back after that some years later. He also did a residency in neurology and a fellowship in clinical genetics at Harvard, and I realized we actually overlapped while we were there and never ran into you there. And in 1993, he became a faculty member at Johns Hopkins School of Medicine. So, Dr. Raymond?
Well, I'd like to thank everyone for inviting me today. I also am realizing that since Ann and I have overlapped for 20 years, many of our slides are the same slide, so you'll get to see it again. Yeah. So yes, I moved from Baltimore to the University of Minnesota. This is our children's hospital. I think that's in the spring. This is last week. No, this is more like January because the snow's already accumulating and not going anywhere. But that is the University of Minnesota campus. Okay, so ALD, which I'm going to predominantly speak about, I'm going to try and teach to the test. So we will cover the things on the test so you could all look good. It's a peroxisomal disorder. Peroxisomal disorders are basically broken down into assembly disorders, which includes Zellweger syndrome, neonatal adrenoleukodystrophy, and infantile reflux. And that group is sometimes referred to as Zellweger spectrum disorder. And then the other peroxisome assembly disorder is rhizomelic chondrodysplasia punctata. And this little stellar pattern here in the corner is actually peroxisome stained with catalase. But over in the single peroxisomal protein disorders, we have X-linked adrenoleukodystrophy, which is the most common peroxisomal disorder, but a whole host of others in the pathway: acyl-CoA oxidase deficiency, multifunctional or bifunctional enzyme deficiency, and then maybe one or two others that you may recognize, including Refsum's disease and hyperoxaluria, but most of these are fairly rare. So X-linked adrenoleukodystrophy is very clearly the most common peroxisomal disorder. So it's X-linked, it's located at XQ28, it has an incidence of about 1 in 17,000. All races are affected, so we don't have founder effects, we don't have one ethnic group being predominantly affected. It's secondary to alterations in peroxisomal ATPase binding cassette protein ABCD1, defects in peroxisomal beta oxidation leading to accumulation of very long-chain fatty acids, and affects myelin, the adrenal cortex, and Leydig cells of the testes. And despite the fact that that abnormality of ABCD1 is pretty much expressed in every cell of the body. You've seen this slide. This is the fatty acid abnormality. I'm not going to dwell on it. And this is the gene, about 20 kb long with about 10 exons. And Ann has updated this. We have a lot of mutations. And so when you call one of Ann or myself or Steve Steinberg and you say, we've got a variation here that's not been previously reported, we shrug our shoulders. We just go, if it's associated with very long-chain fatty acid abnormality in the proband, it's the pathogenic mutation. And we see all of the mutations. This is the biochemical aspect of why we presently think it leads to an abnormality in very long-chain fatty acids. So do I have a mouse cursor? Here we go. So this is the peroxisome in the cell, and this is where we do beta oxidation for very long-chain fatty acids. Just to be clear, yes, I recognize there's two places you do beta oxidation. You do it in the mitochondria, but if you really want to break down a long-chain fatty acid, you need a real organelle. Not something that's just taken up housekeeping. You need the peroxisome. So the peroxisome has this transporter, which is an ABCD1 ALDP protein. And what seems to be is you got a defect of that, and that's blocked. Well, you got these long-chain fatty acids sitting out there in the cytosol, and they continue to elongate. So they continue to be elongated by the endoplasmic reticulum, ELOVL1, and then you start turning out 24s, 26, 28, 30, 32, and nothing is shutting it off. It's not feeding back and telling the system to stop. So years ago, we used to sit around and go, is it defective breakdown or is it too much synthesis? And the answer is yes. It's both. Okay. All right. We're going to go through these in a little bit more detail because that's what I'm here to talk about. So we see these phenotypes, presentations. I'm not sure phenotype is a good word because you're actually not the presentation shifting from the genotype. It's something that can evolve. It's more of a clinical presentation, but phenotype is in the literature. So we have the cerebral in 35 to 40%, diffuse inflammatory demyelination with rapid progression. We have a childhood form. We have adrenal myeloneuropathy, which occurs in 40 to 45%, which is predominantly a distal axonopathy. And as I'll describe, spastic paraparesis in young men, which progresses over decades. We do see Addison's disease only, and that's 20 to 30% of individuals at onset, but it's probably 90% over the lifetime of individuals. So if you look at all the males, 90% of them are going to develop adrenal insufficiency. And most of those individuals are going to develop some neurologic manifestation. We have this asymptomatic phenotype, which I'll talk about. And then, again, women do develop symptoms with age. We're going to talk about all of these things. So this is childhood cerebral disease, and this is what most people think of when they think of adrenoleukodystrophy. These are boys. They're normal, healthy boys, somewhere between 4 to 10 years of age. Again, earliest onset we've ever seen is 2.75 years, but just think 3 years, with a peak age of onset. So this is a boy over here, smiling, he's looking at you. He had a seizure, but usually they start presenting in kindergarten, first grade with some ADHD. Well, the end of the school year didn't go so well. We thought it was the teacher. We waited through the summer. And then things start going off the rails. They start little ADHD or learning disability, and then they start having auditory processing problems. They start having behavioral issues. They seem to regress. They may have vision issues. And I have seen obsessive-compulsive abnormalities. I'm hoping that's one of the right answers. So somewhere along the lines, someone then recognized and said, hey, this is a little bit more. And then once it starts going, it's ugly. Boys stop walking in a month. Boys stop talking. They stop feeding themselves. So this is this boy here. I saw him in December. This is him a year later. He's in a vegetative state. He's G-tube fed, he's blind, he's deaf. And I can't emphasize this enough. He's being hugged here by his older brother in this picture, who has the same biochemical and genetic defect he has and has not developed childhood disease. It's his older brother, okay? Again, the speed of this, so this is a boy in October. He's first grade work, he's crimping the ends of the words. This is him about 8 weeks later. He can't barely put pencil to paper. Something has gone really wrong. And what that something is an inflammatory demyelination. This is an autopsy, needless to say. This is Luxol fast blue staining, and all of this pale stuff should be blue. That is all myelinated fibers that are gone. And what you see is, when you look at it, you see this perivascular cuffing with inflammatory cells, with macrophages stuffed with oil red O. They're just chewing up myelin, and there's all this inflammation there. And when we stain for cytokines, we see all kinds of inflammatory markers. In contrast to this is this disorder, adrenal myeloneuropathy, which is the other neurologic presentation. And, so adult onset, guys usually in their 20s, 30s, if they come in, they say, had walking difficulties for about 10 years. You know, I stopped running after college, but I just figured it was my age. Then I started tripping more, and then my wife started saying, you got to go see a doctor. And then there usually is if there's no family history of this, there's really sort of an odyssey of someone thinks they got hereditary spastic paraparesis or multiple sclerosis, until someone does the next study, which is very long-chain fatty acids, and says, they're elevated. Well, we'll do them again. That can't be right, because that's a rare disease. And it turns out to be the case. You know, so it's spastic paraparesis, sensory involvement, bladder dysfunction, really a gradual progression. And it is consistent with a normal lifespan. I've got plenty of 70 and 80-year-old individuals who call me up and ask me when I'm going to have the cure for them. But cerebral disease does occur in about approximately 20 to 40% of those individuals. And this is what we see. Again, pathologically, it's non-inflammatory. So if you're looking for those inflammatory markers, you're not seeing anything. But again, this is the spinal cord. I recognize that the rest of the room are not neuropathologists. But there's pallor here of what should be stained. And that's, again, there's demyelination. You don't really see much on MRI. So people always ask me, should we MRI a spine? I say no, because it's just a little thin. You don't see things like you see in MS. But we'll talk about how to monitor these individuals in a few slides. Adrenal insufficiency, I got a lot of slides later on about the treatment of adrenal insufficiency, because I do think when we start talking about incorporating this into newborn screening programs and how you monitor individuals, you have to be in conversation with your pediatric endocrinologist. It's primary adrenal cortical dysfunction. It can present acutely or chronically, low blood sugar, difficulty fighting infections, dehydration, hyperpigmentation. We're going to go over these things. I have a few other slides about this later on. Rarely that low sodium, high potassium that they teach medical students for Addison's disease. And it's a leading cause of adrenal insufficiency in males. I think the word is out to pediatric endocrinologists. They know that if they got a boy with a primary adrenal insufficiency, this needs to be tested for. Not so certain about some of the adult people. I keep asking them, they go, oh yeah, we know about that, but they're talking to me, you know, so they know that they need to be on their game. I don't know about how much that's actually known in the community in the adult world. And as I said, the majority will develop neurologic manifestations. And then we have this asymptomatic phenotype. These are boys with a normal brain MRI, no adrenal insufficiency, diagnosed by very long-chain fatty acid screening of relatives of known ALD patients in the past. The future is going to be everyone you folks diagnose is going to be in that asymptomatic phenotype. Okay, and heterozygotes. That's a low estimate. 20 to 50% of women who are carriers will develop symptoms. Unfortunately, I think it's probably closer to 70 to 80% with age, depending on how you define where you're going to capture them. It's a myelopathy, and that means spastic paraparesis. That means they have walking difficulties. They have tingling and burning in their feet. They have bladder-involved symptoms. But they rarely get cerebral disease or adrenal disease. And I don't understand that, but that's the way it is. Okay. Once again, and I got lots of slides that will emphasize this because I don't want to lose that perspective that the gene defect, finding that mutation, even if it's been previously reported, does not predict what the phenotype is, what the presentation is going to be. And while a genetic modifier has been postulated, we're not so certain about that. So I think this family over here, this is a boy who died of childhood cerebral disease, and his older or a younger individual in that family went on to develop AMN. And over here, you know, grandpa's got AMN, and the two grandsons have childhood adrenal insufficiency, but there's no anticipation or anything like that. It just, you see these big pedigrees with all varieties of manifestation in them. Okay, so what do we do about prospective clinical monitoring? And I'm going to highlight three things, knowing that Beth is also going to follow me and talk a little bit about talk a lot about the genetic evaluation and what the genetic counselor's role is. But I break it down into three things when I talk about management. I think about genetic evaluation, endocrine evaluation, and neurologic assessment. And the endocrine evaluation is primarily around adrenal insufficiency when we talk about boys, but a little bit later on, we're going to tweak that a little bit. I think I have one or two slides about genetic evaluation, not to steal all of Beth's thunder. So when you make this diagnosis, you have to sit down with people, and you have to talk about the diagnosis and nature of the disorder, and you have to kind of lay it out. And I think when newborn outreach programs are talking about this, they have to have the full spectrum here in mind, and not just the child in front of them. So you get diagnosis and nature of the disorder, coordination of the subsequent surveillance, identification of the mutation needs to be taken on, identification and evaluation of other at-risk family members, because you're going to see, there's going to be a mother, or if you're identifying the newborn girl, it might be the father. And we're going to have to deal with all of these things as we go forward. Coordination of testing of other family members, and counseling and care of the identified family members. Some of this is going to be long distance, and some of this is going to be right in your state. This is an X-linked disorder, so you got this proband here. You identify his mother's a carrier, and as testing occurs, suddenly you got this large X-linked pedigree to deal with, and you're not going to deal with all of it, and and I don't get to deal with all of it, but you do have to sometimes say, okay, that person, we got these, mouse, please thank. We got these family members here in Minnesota, but these people are over here now in California, and so you got to be able to outreach to them, and hook them up with genetic providers. And this is just the nature of X-linked disorders. And whether we're, it's nothing specific to adrenal leukodystrophy. It could be, it could be hemophilia. It could be, Duchenne's muscular dystrophy. These are just a way of X-linked disorders. Okay. In terms of the endocrinology, for the boy, we really need to establish care with pediatric endocrinology. Don't have them calling me. I'm not a pediatric endocrinologist. This is nuanced. This is, I'm going to put out a whole bunch of things that I think need to be thought about, but the pediatric endocrinologist really needs to do this, because this is high-stakes stuff. There needs to be monitoring for primary adrenal insufficiency, and I think ACTH and cortisol levels are sufficient. ACTH stimulation tests are where you give them IV ACTH and you watch their cortisol response. That's when you're suspecting that there may be adrenal insufficiency in someone who's got kind of squishy symptoms. I don't think it has as much role in this group of disorders because adrenal insufficiency is coming. But I don't argue with my endocrine colleagues much. I have friendly discussions with them. Replacement steroids, which we are going to emphasize, are life-saving and lifelong. I'd like to emphasize this reference. This reference came out almost simultaneously with a lot of our early work in newborn screening. And I must admit, it couldn't have come at a better time, because it talks to all the talking points that I've been emphasizing for my emphasis in newborn screening for ALD. One is adrenal insufficiency kills. We have lost boys to not being diagnosed and presenting at 2 years of age with primary adrenal insufficiency, and ED attendings or pediatricians or family practitioners just don't recognize it. And I can't emphasize that enough, that this is a preventable cause of morbidity and mortality. And really is the primary drive behind a lot of this. So this structure over here is the adrenal gland, the adrenal cortex. This is the anterior pituitary. It's one of the first described feedback loops, actually, in the body. So when the adrenal gland starts to fail, and it's the adrenal gland that's failing here in ALD, it starts to shrivel up, becomes fibrotic, it's not sending the cortisol back to the pituitary. And so the body keeps going, hey, we need some more cortisol, and we're not getting any cortisol here, and ACTH keeps pumping out. Well, but you can pump all the ACTH out you want. That gland is now a little bit of a walnut. It's not as big as it's supposed to be. And so you get glucocorticoid deficiency, you get mineralocorticoid deficiency, and you get high ACTH. And things that stress, where you want to put out more, you're getting no response. How early can we see this in ALD? Well, we actually looked at this. And so what we did is we took a whole bunch of boys who were coming to attention because they were just being screened because of other family members. And this, kind of walk you through this. This little dotted line is the upper limit of normal for ACTH. So I want to focus your attention down here. There is a whole bunch of boys who are being screened who already have elevated ACTH. Now, they may not have overt adrenal insufficiency, but they're on their way. So you never know what that little push is going to be when they try to get a little bit more, and it's not, the system's not going to be responsive to them either. So even less than 2 years of age, the majority of our individuals were already trending in an abnormal direction. And as I said, I have personal experience with a 22-month-old who died of adrenal insufficiency. Okay. So what are we going to do about it? Well, there's physiologic replacement. It's one of those easy fixes. It's not even like diabetes where you got to give them shots. This is an oral agent. We give them a maintenance dose of glucocorticoid, which is based pretty much on what the body was supposed to put out anyways. And just to kind of go through this, the body has this little circadian rhythm for cortisol. So about 4 a.m., it starts to pump out cortisol. So by a little bit after 8 in this individual, we're at our maximum cortisol for the day. I actually kind of wonder if it's one of the reasons our brain says wake up at that time, is that this surge of cortisol. And then it rides down, and then there's another little peak, and then tapers off towards the end of the day. In this, people have talked about what's the baseline rate. The replacement is about 9 to 12 milligrams per meter squared. And pediatric endocrinologists like to do it every 8 hours, and most of them give a slightly bigger dose in the morning to try and mimic that diurnal variation. And this is where there's art behind the replacement. And you want to give enough, but you don't want to give too much, and you want to monitor their growth. One of the things about the Schulman paper, which is that we can't use ACTH as a criteria for replacement. Because if you drive the ACTH to low levels, you're giving them too much, and they're going to be actually switch them over to cushingoid appearance. Again, there's this thing called acute adrenal crisis, which is a life-threatening emergency. And you need to have rapid restoration of intravascular volume with isotonic saline, treatment of hypoglycemia with glucose, and stress doses of glucocorticoid. And you need all three. Because if you just give them fluids and glucose and you don't give them steroids, they're going to die. So you need all three. Now, this is what you do when you know the patient's got this, and so so even if you know that they've got it, they show up, they're sick, they've not gotten enough for that day, this is how you treat them. But if you suspect it, you also have to step up and do that. So the Schulman paper, which came out of the Lawrence Wilkins, it came out of the Wilkins Society, which is the Pediatric Endocrine Society, came out with these guidelines how to deal with your patient with known adrenal insufficiency. And just wanted to kind of go through this. Again, the morbidity and mortality, even when you know it, is still unnecessarily high. And so, well, every probably pediatric, well, every, I think, medical student knows what diabetes looks like. You know, diabetic ketoacidosis. They don't know what, they don't recognize adrenal insufficiency. We have to give, and they don't take it seriously enough. We have to give written instructions to families regarding how and when to increase their dosing. Instructions when to seek medical consultation. So if the child is vomiting, don't put him to bed that night. Talk to your doctor, because he may be about to enter a crisis, become hypoglycemic. You need to have letters to the local emergency departments identifying that individual and diagnosis. I can't tell you the times I've gotten calls, we're sitting in the waiting room because the triage nurse is not seeing him even though he's vomiting. That's not appropriate. And we need to have outreach to our emergency departments to say, this kid comes in with these symptoms, he needs to be seen immediately, taken right back, like any other emergency there. You need to have intramuscular injections in case of vomiting or severe stress. I can't tell you the amount of patients I have to lecture to tell them, where's your medical alert bracelet? They all need medical alert bracelets. My genetic counselor has gotten really good at this. She almost warns them before they come in. Do you have your bracelet with you? He's going to lecture you. Hypoglycemia can be part of this, and so for really young children, it's probably best to have methods to monitor hypoglycemia and have them have the glucose gel so that the babies, for older children, can get corrected pretty quickly. Continuing education is needed for primary care and emergency departments, and actually, Janice Sherwood, who is involved in the ALD community, drives her van around and instructs local hospitals on adrenal insufficiency. And this is something that keeps many of us up who deal with adrenal leukodystrophy frequently, is some individuals may not be capable of recognizing their crises when they're getting sick. You know, they start becoming hypotensive, hypoglycemic, they're not thinking. So what, you know, as a parent of a young adult, you know, it gives us all pause, you know, sending them off to college or sending them off somewhere else. Is he going to recognize that he's getting sick? And has he told his roommate that if he starts getting sick, that this needs to be done? And is the school nurse going to, you know, these are issues, but not all for the newborn screeners. Okay, neurologic evaluation and management. Okay, as I said, way back when we had that little boy, and you know, how do you make this diagnosis when it's not, you don't know it's in the family? Well, we make it on MRI. Someone finally goes, this is an ADHD, or this is way different than I was expecting for his learning disability, and gets an MRI. And this is sort of cuts this way. It's what's referred to as a T2 weighted image, but you don't actually have to know this. This is what normal myelin should look like. It's all black here. This bright stuff here is just the ventricles, but all of this back here is the myelin involved, and if someone gives contrast, you get this garland of enhancement, this bright ring, and that's almost pathognomonic of ALD. But about 85% of them is in the back of the brain here. This is the posterior aspect, which means about 10 to 15% are up here, and there's a small smatterings of other presentations. And so this is what everyone gets taught is what ALD looks like. And we actually have an ALD scoring system where we count the areas of the brain that are involved in something. So this is the ALD MRI score. And I'm going to bring you in on all the secret. It's pronounced less. So it's not lows, it's less. Dan Less is a neuroradiologist. He's actually in Minnesota, and very good, very nice person. He'll take your call, but the same way. I'm always happy to score your MRIs for you. But the honest answer is you don't wake up one morning with your MRI looking that ugly. So it starts this way. It starts with a little bright signal here in that structure, which is the splenium of the corpus callosum. It might start up here in the genu of the corpus callosum. But this is how it starts. And that, just to be clear, that we refer to that as a ditzel. It's the medical scientific term. And then it starts to spread out a little bit more. That took a year. And we've actually sat down and sort of tabulated what's sort of the rate of progression for those early lesions. So just, this is pattern 1, this is posterior disease. This is pattern 2, it's anterior disease. This is pattern 3, it's just the cortical spinal tract. This is the spinal cerebellar pattern, which is pattern 4. And this is pattern 5, which is kind of both anterior and posterior. But if you look, this is over a year, MRI progression over a year. So you can see pattern 1, it's going, less scores increasing by 1 to 2 points. So that means we started, let me go back one slide. So we start with this, which is a less score of 1. And now 1 year later, we're a less score of 1, 2. We have a large window of opportunity here, if we're monitoring, to intervene. Got probably 2 to 3 years. So while the disease clinically looks like it's really rapid, the MRI is leading this by years. So we have this window of opportunity to step forward. Okay. So the MR recommendations have kind of come out over time. And this was my best recollection of what we were doing, what I recommended in New York. And so if Beth comes up and says something a little different, we will reconcile this. But up for the first year of life, really don't need to do anything in terms of MR magnetic resonance imaging. But about 12 to 18 months, they need their first MRI. And then I usually repeat them yearly up until about 3 years of age. Remember, because that's the earliest point which we saw childhood cerebral disease. And then from about 3 to 10 years of age, MRIs every 6 months. This is your peak incidence of childhood cerebral disease. And as we're going to talk about therapies in 1 or 2 slides, this is where we can intervene. 10 years of age and older, I still recommend every year. One MRI a year with no upper age limit, because they can develop cerebral disease even in adulthood. Now, I recognize that getting a 24-year-old in to get an MRI yearly, sometimes we stretch it out to 2 years, but we try, these are recommendations we try to adhere to. This is sort of what I think of still as best practice. Now, I talked about MRI rating scales. We actually have a neurologic rating scale, functional rating scale. And this came about because these are the things that get affected in childhood cerebral disease. I'm going to say that if you attend to the details about the MRI rating scale, you'll never need to use this because they'll never become symptomatic. Even when their MRI becomes abnormal, they will still be asymptomatic, and you won't need to attend to this. But we do have ways of sort of rating individuals neurologically. Okay, I actually have only one, even though I'm at the University of Minnesota, it's probably sacrilege to say this, I only have one slide on bone marrow transplant. Bone marrow transplant is sort of the colloquial way. What we're actually doing is hematopoietic stem cell transplant. So we don't actually just take someone else's bone marrow and inject that kind of mixed group of cells into someone else. They take it out, they purify it down now to CD34 cells, which are the cells which are stem cells for all the bone marrow lineage lines, and that's what they transplant after they've given chemotherapy and specific preparatory regimens. And there's the rub. We're giving chemotherapy, and we're actually injecting someone else's stem cells. Now, it may be umbilical cord stem cells, it may be a sibling's stem cells, it may be an unrelated donor stem cells, but those are what we are basically re-injecting here. Now, it is effective in early cerebral disease. So this graph over here shows that in early cerebral disease, there is about a 95% survival with a very good outcome. We don't understand why this works. It arrests disease progression through uncertain mechanism, although my thinking is that we're giving a metabolically competent immune system so that they're not caring about these very long-chain fatty acids and they're not triggering the rest of the cascade. It's not a walk in the park, though. And actually, every once in a while, when we get a little cocky about this, it has a way of slapping us. We see transplant-related mortality, death. Not just sick kids, but death, in about 14%. And that's why it's not indicated in asymptomatic boys. So you take a 2-year-old and say, why don't we just transplant him now? Well, because he may not develop childhood cerebral disease. And if you transplant that child and he dies, and he wasn't going to get cerebral disease, I don't know if you can be that angry from the grave, but you've robbed him of living into his 20s and 30s just because you didn't want to deal with the anxiety of the fact that he might develop adrenal myeloneuropathy and he needed some monitoring. So our best candidates are routinely screened individuals who are known to be at risk. Okay, gene therapy is here. Well, it's here in a trial. And as a disclaimer, I am someone who is involved in a gene therapy trial in adrenal leukodystrophy, where this is experience from the French group. Hematopoietic stem cells, where they take out the stem cells of the boy and transduce them with a vector and then reinsert them. So this is an autologous transplant. We're not giving them someone else's stem cells. We're giving them back their own modified stem cells. And in 4 boys, and this was reported by Cartier et al. Back a number of years ago, 4 boys with early cerebral disease who did not have an HLA match, they had stabilization of the disease at 1 year of age. And it seems to be getting better. There are new vectors, there's a company involved, and we have a trial going on. And if anyone wants to talk to me about it at the break, I'm happy to discuss it. Okay, so what do you do? Okay, we've identified a boy, a newborn, but he's got an older cousin, or we've got uncles. What are you going to do with them? We have once again, I still think they should get genetic counseling of some sort to explain the disease. They need endocrine testing. There's adrenal insufficiency. There's some growth issues. I think they need to see an endocrinologist. It affects the Leydig cells of the testes. There could be issues around pubertal development. So you may now be explaining a whole host of issues around that. Neurologic assessment. They need MRIs. They need MRIs, and they need them yearly. Okay, how do we treat ALD in adults? I have one slide on this and one slide for women. Adrenal replacement, easy. They develop that spastic paraparesis, so they do benefit from physical therapy and exercise. They may benefit from muscle relaxants. They benefit from seeing a neurologist or a physical medicine person who's experienced with spastic paraparesis. They have bladder issues. They may respond to ditropan, detrol, and you need to prevent infections because if they got adrenal insufficiency and they get a bladder infection, they're in your ICU. And then they may have a neuropathy, and we use gabapentin and pregabalin, which is Lyrica. And I have dosages for all of those things if you're interested. Symptomatic women. They're not rare. Their disability is significant. It seems to be a function of age, but I see it in 20-year-old women if you're looking for it, because they know that they're carriers. That's why they come to me. But and there's no correlation within families, which
it's one of those things that really can make sisters angry at each other. My sister, here I am using a walker, and my sister is fine. Get into these whole sibling issues. People talk about being a factor of X in activation. I'm not so certain, but I'm happy to debate that. Cerebral disease is very rare. They don't need MRIs routinely, and adrenal insufficiency is very rare. Although a lot of women seem to have thyroid disease, but I'm biased, so I don't know if that's a real. I have to compare that to the rest of the population or not. And then again, we treat their pain. They have a lot of dysesthesia. We use Neurontin and Lyrica. Cymbalta is a nice agent. Bladder issues, Detrol, Levsin, Ditropan, and there's others. Some women actually have to self-cath. Spasticity, exercise, PT, and anti-spasticity medications are out there. And the reason I'm sort of bringing this up is that one of the geneticists in New York State, emailed me a couple weeks ago and said, yeah, we identified a little girl, newborn baby girl, but her mother's in the office saying she's got symptoms. What do I do with her? I said send her to the neurologist, but I'm also trying to help people start to think about these issues. Okay, I wasn't planning on talking about Lorenzo's oil. It's available via IND through expanded access. There is some evidence that it may be a preventative therapy for childhood cerebral disease. I hold the IND. It is something that is not the purpose behind newborn screening. I'm not promulgating Lorenzo's oil as a therapy for those individuals identified. But if you want to discuss it, we can discuss it. There's a lot of interest presently in antioxidants, especially for the older individuals, and one of them is pioglitazone, which is a oral hypoglycemic, but it may have some impact. And then lovastatin got put out there almost 20 years ago, and with a little bit of positive data, and the negative data has never caught up with it, but it's not useful. I just wanted to kind of put it out there because I do get questions still about it. Okay. Once again, it wasn't my intent to talk about peroxisomal disorders, but Zellweger spectrum and the single enzyme disorders, which include bifunctional enzyme, are all going to be picked up by these assays. So once you've made that diagnosis, you can also look at your clinical situation, but then you have to kind of confirm it biochemically or now by genetic analysis. And there's a lot of places now offering next-gen sequencing for this. And so I think a lot of what was the traditional biochemical diagnostic algorithm is going to go away just by saying, I'm going to send the panel. All are autosomal recessive, multi-system disorders, and there's a group of us that are still very much interested in this group of disorders, and we are coming up with some standardized recommendations. We have something on gene reviews, and I wasn't going to go through all of the recommendations because they're sort of distracting from the purposes of ALD, but we are also coming together with another paper we hope will come out within the year, where we'll emphasize some standardized recommendations on how to diagnose and what to do. Ann wasn't kidding. We've got a lot of collaborators, a lot of friends. We've worked on over the years, and when I kind of bring these slides together, it's like this isn't just my work or Ann's work. This is a very collaborative effort, and we have a lot of people to thank. And I thank you for your time. I don't know if Michelle want me to take questions, or go ahead.
Did you mention the pathology in the adrenal gland?
So you actually look at the pathology. The question is I didn't mention the pathology in the adrenal gland. It's predominantly, my understanding is it actually looks a little bit like storage abnormalities, and so initially, the cells are packed with very long chain fatty acids and these crystalline structures, and then it just kind of it fibroses. And the trouble is, a lot of this, if you get the post-mortem, a lot of it's just streaky remnants. And so it's a little difficult to look at the evolution of it. And I must admit, I'm intrigued by the possibility that there might be an inflammatory component to it, but there's just not enough work done on it yet. Go ahead, there's a follow-up. No, go ahead, you can ask your follow-up.
You said, for the early onset form, it's inflammatory demonic.
Right.
The later onset form, not inflammatory.
Not as clearly an inflammatory aspect. So if you look traditionally, as pathologists do, for inflammatory cells and things like that, you don't see them. Go ahead.
You mentioned earlier that there are a group of asymptomatic people who remain asymptomatic. Do you have any idea amongst the families that you've looked at what proportion of the
What?
biochemically positive people those are?
No, actually, I apologize if I gave that impression. I think everyone who's got this biochemical defect will eventually develop some symptoms. It's just a matter of pointing out at what age. So it's a decreasing percentage as they age. I have never seen a 60-year-old man with this biochemical abnormality who I couldn't look at and say he's got walking difficulties. But if I look at 5-year-old boys, the vast majority of them will be asymptomatic, although some of them will have, then some of them start to have adrenal insufficiency, and then some of them start to have neurologic issues. And so that number gradually goes away with time. Okay, do you understand?
Yes.
Okay. Go ahead.
I was curious, you had families with used therapy?
Yes, we've had families who have chosen not to. What? Oh, see, because part of that becomes where we sit. So if they come to us, they've already just kind of voted with their feet. But I think there are clearly families out there for a variety of issues, whether it be religious, cultural, or whatever, have decided not to go with transplant. Although my sense is that most families who have decided not to go with transplant, it's because there's already a question that the disease is already too advanced. Those families who have been monitored appropriately, I can only think of 2 or 3 families in 20-something years who have not gone for transplant. Go ahead.
I have a question. My N of 1, a transplanted APL patient, did back in 1990, and he got written up very positively, but he really was still very handicapped.
That's
So
so. For one thing, 1990 transplants are very much a different. 2014 transplants are different than 1990. I want to be very clear about that. 2. I am aware. I do aware of sometimes some skewing of the literature also. And then thirdly, though, I have seen some great outcomes. So there was a boy. We're going to talk anecdotes. There's a boy I had transplanted probably about 10 years ago, and he's in nursing school. And he's going to go on to a graduate program.
what's he like when he transplanted?
He was asymptomatic. He had an MRI abnormality. He had adrenal insufficiency. But that's what you need to transplant. And it broke. You're taking a boy who, and that becomes a hard part of the discussion. Is you're going, yes, I understand he's completely asymptomatic. He's in kindergarten getting great grades, but this is why we've been monitoring. His MRI is abnormal. It's turned abnormal now. We should transplant him. Those are the kids. That's who I want.
So this was a 7-year-old. He was doing good at the beginning of the school year. Fine.
So there are already neurologic symptoms at that point. And yeah, we'll transplant him, and yes, he's still alive, and that's a great thing because it's better than being dead. But we never say that it's going to be perfect for those. And
That was a bone marrow transplant?
what?
Yeah, that was a bone marrow. Nursing student.
Oh yeah, he had a bone marrow transplant. Yeah, he had a bone marrow transplant. There's another individual who's working. There are individuals who are working. There's another individual I'm aware of is working in Boston. I just saw the first individual who survived in the United States is a walking, talking young man. He's got a variety. He's got probably some mild neuropsychiatric issues, but he can hold a job. He's 33 years old, and I saw him the other day. So, go ahead.
One of your slides seemed to say that there was a 15% mortality, but
There's a little bit of talking different kinds of apples there. That's an issue. So so when you look at that slide, which talks about this 5 to 6% mortality, is cherry picking the entry criteria into the comparison group. So you had to have an MRI score less than 9, you had to have an IQ greater than 80. So we typically try to bend those rules, but if you look at the aggregate mortality, it seems to be about 14% of transplanted patients. Yeah. No, we can make this a complicated discussion. We quote people about a 10 to 15% mortality. Your mortality is higher if you're not in the prime selection group, and that's a problem. Go ahead, sir.
What mechanisms drive the inflammatory response among the early onset cases?
We do not know. You know, that's an excellent question. I would love to know, what are these triggers? Is it the very long chain fatty acids? Is it then something? And then what's the body's response to this? We don't know all those steps yet. And clearly, oh, speaking to the microphone, the man is saying it from the back. Clearly, there are some interesting cases that just drive us crazy. There seems to be a very good concordance in identical twins. But there's at least one case report out there of a set of identical twins where one twin developed childhood cerebral disease and the other twin did not. And it's just, there's more to this than we clearly understand.
And the second part of that question, are there epigenetic factors that do affect
An ongoing area of investigation. That's the best I can say, you know, because people have done sort of genome-wide associative studies, and you kind of get a whole bunch of smatterings. And I have a colleague who wants to actually tackle that question directly. Go ahead. Other questions? All right, I'm going to go there. So if you just look at immune suppression without bone, so say you've got someone individual who's developed cerebral disease and you want to just do strong immunosuppression. No, it doesn't work. So high dose steroids, Cytoxin, beta interferon, all of these things have been tried, and IVIG. I got a laundry list. They've all been tried. They don't seem to arrest. Now, it begs the question, what if we started earlier, or what, you know, and those trials just haven't been done. Next, go ahead.
Okay, so you pick up the babies, newborn screening, and find that grandma who's having difficulty walking.
Mm-hmm.
So you said you were going to tell us what can you do with the women.
What?
And the second part was, what's with the exon activation stuff?
Oh, okay. So grandma's got trouble walking. I think, frankly, you're the newborn screening program. Send them to a neurologist. No. Yeah. No, but you know, and the adult neurologist, because but no, you can pick up the phone and call me too. But no, seriously, I emphasize exercise. We have some evidence that heterozygotes do, we have lots of things we do beside newborn screening. We have some evidence that exercise makes these individuals stronger. They do better for what they've got. If they need an antispasticity agent, we will prescribe it. Sometimes they just need to see PT. And you know, sometimes they need a walking stick or a walker and keep them safe. Oftentimes we find women need things for pain. Their feet burn. And that's Lyrica, Cymbalta, Neurontin, and
oftentimes they are having bladder symptoms that we need to address. So it's a multidisciplinary sort of group, but oftentimes the neurologists who are dealing with either MS or spastic paraparesis have these resources. They go, oh yeah, I use this guy as my, or I use this woman as my urologist, I use this person as my physical medicine person, I got a great PT. These are you got to plug them in. The second thing about exon activation, which really hasn't explained it to me, is one is the studies that have shown exon activation have been so-so in their how much they correlate with the disease. The second thing that I've never quite understood is why it's a function of age if it's exon activation, you know, and why. So I don't find exon activation a particularly great hypothesis. I actually do wonder more about neuronal aging and maybe even mitochondrial functions changing over time that actually make a little bit more sense to me. Much like, why does Parkinson's disease only occur in older individuals, or ALS only occur in older individuals? So there's the aging here of the CNS that I think is probably going to come into play.
So even those individuals who do get the inflammatory cerebral form, some of them do arrest. So do these less scores help in predicting that also?
Not as well as we would like. Yes, there is about 10%, 10 to 15% of boys who develop changes on their MRI do seem to arrest. The one thing that's seen, and we are looking at that. One of the things that does seem to, the things that seem to correlate with progression or non-progression is if they have GAD enhancement. If you have GAD enhancement, you're probably not going to arrest. If you're young, you're probably not going to arrest. And some families don't do well with that. You know, some families you go to them and you go, he may arrest, and they go, and they don't care. They just want to move forward. Other families say, okay, we'll continue to do MRIs routinely. And one of the things we sometimes do is parallel track them. You know, it's like, okay, this may not be progressing as quickly as I like, but at least I can find out who's an HLA match, and so that if we need to go, we go. And if it continues to creep out, we just go. What? Go ahead.
And the second question was like, so we do have to tell them that this is not going to suppress polio A and coming on later, right?
Yeah, it doesn't seem to be.
I'm a pediatric endocrinologist from New Jersey.
Okay.
Famous why I'm here. And the question, I'm not sure you're the right one to answer this, but compared to the 54 other screens that we're doing now, what you do with the screening result for this test is extraordinarily complex. You're dealing with multiple generations, multiple different potential outcomes, lack of correlation between the test results and the clinical outcome.
I'm going to beg to differ just a little bit. Okay, I don't think it's all that. I don't think it's all that complex, and I think we've got clinical experience to indicate. Yes, we are. You're transforming. You are transforming this into an ongoing surveillance process. But 90% of males are still going to develop adrenal insufficiency. 35% are still going to develop childhood cerebral disease, and so yes, there is steps that you need to take, but they're not insurmountable steps, and we have that technology there for us. Compared to some other disorders, which may or may not be disorders that are picked up on newborn screening, yes, you set them off on sort of a lifelong trajectory here of monitoring to keep them healthy, but you do have an abnormality you're dealing with. Go ahead.
Well, along that line, I'm Bob Currier from California. Along that line, and you may not be the person to answer this.
I can answer anything.
Well, it's about insurance coverage for
Never have had a problem.
Including when the baby is identified by screening?
Yeah, never have had a problem. And part of my going forward guarantee is I'm happy to speak to any insurance company on the phone to get them their MRI, and I tell them I'm an international expert. Put someone on the phone who's comparable to me, and I will argue it. Yes, there are two ICD-9 10 codes, and that one is 279.8. Don't quote me on that one, and the other one's 330.0.
So even though they're asymptomatic,
Right.
because
They have a biochemical defect. Yeah.
you're coding them as
Yeah.
ALD.
Right.
And that's why you're getting the analyzed picture.
Yeah. Go ahead.
I have sort of a similar question for endocrinologists. From a public health point of view, planning newborn screening, the outcome you're looking at is it fair to say every male who is detected will eventually need some intervention, and therefore it's a useful thing to screen for?
Yes,
That's the case.
that's the case.
It might be 2 years old, might be 10 years old, might be 60, but all of them, or almost all of them, you can do something good for them if you pick them up early.
That is correct. That is correct.
There's much more uncertainty with crab A.
What?
There's more uncertainty with some of the crab A's we pick up.
I'm not going to go there. Go ahead, Beth.
My question is for both you and Ann. I know we've had this discussion before, but it brought it back to my mind from listening to your presentation. Most newborn screen samples are deal sticks, but we know that sometimes they'll take venous blood and put it on the card. From looking at your data, Joe and I were kind of looking at each other going, uh-oh, we worry, are we going to miss? If they do that and it's lower, is that a concern?
Go ahead, Joe.
Did I understand you correctly that post-treatment stem cells in children where patients still have abstinence, they're still required?
Oh, absolutely. Oh, yeah. You're not fit. If that adrenal gland is a little shriveled fibrotic band, there's no amount of stem cell therapy that's going to bring that back. I don't know that this is the forum. I think there are adrenal gland transplants out there, and I'm trying to get our transplant program to step forward and do that. It's not as hard as it sounds, and so I think if we get a good enough plan in place, we could actually pilot a program. But that's a simple enough step to take in the future. But no, you don't. Once you've had a bone marrow transplant, those adrenal glands are gone. Well, plus the fact that when you do bone marrow transplant, by its very nature, they give them high-dose steroids as immunosuppression, and so any hope that adrenal gland had of being an adrenal gland for another year or two is gone. It's been suppressed, and it never comes back. No, because if you actually look at the population, so the long-term C26 levels, the body makes a lot of C26 in other organs, and all you're giving is predominantly 10% of a cell population. Yeah, just the white cells. And so, you're not transplanting the liver, you're not transplanting these other things, and so the very long-chain fatty acids themselves do not diminish. And, or if they do so, they don't do so significantly. There's a lot of interest in what happens to the boys who've been transplanted into adulthood because their very long-chain fatty acids are not all that significantly lowered. Now, there's two schools of thought. One is that they should develop an AMN type phenotype with some time. We don't know that. And then there's others who say, well, no, we've given them a new immune system, and maybe still they won't develop AMN. The jury is still out. And there's ways of getting at this, and we're trying to move a study ahead to answer that question.
So when you tell those families that want to get transplanted, you lay all this out for them that there's a possibility and what you want.
Oh, absolutely. Absolutely. If we don't make them cry, we haven't done our job. No, they're told all kinds of things. And there's actually they're actually told in 2 sessions. They're told initially, and then there's an exit session about a week later where they're told, where it's all gone through again. Go ahead.
So, returning to the screening aspect of things, if we look at these really little babies in the NICU, let's say 1,500 grams, the CLSI guidelines say collect one when they get to the NICU, another one at 2 or 3 days, and one at 28 days. Which, if any of those, will start to show the
All of them should.
abnormality?
I'm fairly confident that all of them should. This is something we can detect prenatally. We can detect with chorionic villi sampling. I'm actually fairly confident that we will see a biochemical abnormality in a 25-weeker. I can't say specifically that I could point to a 25-weeker in our sampling in Maryland, but I'm, based upon everything I know about the biology of this condition, I'm fairly confident. Joe?
I can tell you that we don't see variation, in age. There's nothing that stands out. I look at the data, and every kid's got every day, and end of our day, the samples are all repeat samples, and we have day of birth samples in this, and you don't see any kind of profile associated with it.
Let's take a break.
All right, thank you very much.
Change the schedule just a little bit. So I wanted to thank Ann and Dr. Raymond again. The help that they've given us in implementing Screen in New York has been invaluable, and always answer phone calls, return emails, talk to parents, talk to providers, et cetera. So thanks for that. And when we were planning that, he rearranged his whole schedule to come in on our conference calls, so that was very helpful because we implemented in a pretty short time frame. He also gave you most of the answers to the test in that talk, so that was good.